Let's make a start, shall we? So good morning, everyone. I'd like to extend a very warm welcome to you all. And thank you very much for joining our patient event today. This is our third patient event this year. And I'm most grateful to SarcoidosisUK, the charity, for actually hosting this event and for all the support they're giving us and our patients. So I'm going to share the screen so we can talk through the program. So hopefully you can read some of the program on the screen here. So we're very fortunate that we've got key members of our service who are all talking today. The message really is that today is about you. It's about patients. It's about how we can improve our service for patients with cardiac sarcoidosis. And what we've done with the program is to try and make it interactive. So after each session, we do have time allocated for Q&A and for discussion. Do post your questions on the chat function, and we'll try our best to go through as many of the questions as possible. This session is being recorded, so for those of you and friends and relatives who can't join today, you will have the opportunity to listen in afterwards. And we know that this has proved popular in the past. So I'll begin by just introducing the service. I'll talk about our team structure, because this is very much a team-based service. We'll talk a little bit about the vision for the future and what we're planning in terms of making the service more responsive for patients. Again, as I say, there'll be Q&A after that session. Then Vasilis Karanis, our cardiac sarcoidosis research lead and consultant respiratory physician, will talk about our research aspects. And certainly in the last few months, we've expanded our research department because there's a lot of questions which we need to answer for our patients. And the only way which we can do this is with your help in our research programs. We're very fortunate that we have Dr. Peter Tischborn, who's the executive chair for the SarcoidosisUK charity, who'll be joining us today and talking about clinical and research aspects for cardiac sarcoidosis patients. And then in the afternoon, what we thought we'd do is we'd go through a case, because a lot of what we do in our kind of weekly clinical commitments is discuss cases in an MDT format, and we'll take you through a case just to show you how we discuss the diagnosis and management of patients with cardiac sarcoidosis. Now, the team wouldn't be complete and is in fact very dependent on our imaging experts, because they're key to the diagnosis and management. So our imaging consultants will be talking through the role of imaging and what we should expect and what patients can expect when they come for their scans. Then for the final session, we'll be focusing on treatment. Professor Arthur Wells will be joining for that session as well. And we'll talk about cardiac and respiratory treatment, which involves drugs, involves devices, arrhythmia management, and so on. So as I say, there's quite a packed program. Hopefully you'll enjoy it, and hopefully you'll ask questions, and we'll try and keep this as interactive as possible. So I'm now going to go on to my slides.
I don't know whether Leo wants to have to give a word or anything to the patients. Leo, would you like to introduce yourself as well?
Absolutely, yes. So hello everyone, my name is Leo and I'm the Senior Executive here at SarcoidosisUK. And I really just quickly want to say before I hand you back over, thank you so much for being here, and a huge thank you to the Royal Brompton and Hayfield Hospitals for helping us put on these events for the patients, which are so important. If you require any support, we are always here to support you, so please do get in touch with us. You can send us an email on info@sarcoidosisuk.org, and we really are here to support you in any way that we can. So a huge thank you to everyone for joining us. Thank you to all of the speakers today, and I know that it'll be a really informative and interesting event. I'll hand you back over.
Thank you very much, Leo. So yeah, that's very good. So I'm just going to share my screen now so we can go through the slides. Good. Okay, so I'm just going to spend a few minutes just to discuss our team structure, because as I said earlier, a lot of what we do is very much dependent on the team. I'll talk through why it's important to have a team structure for managing patients with multidisciplinary team conditions, and also the vision we have in terms of our research and how we hope to involve patients even more interactively with our service. So this is a slide just to illustrate how things were before the pandemic era. So previously, when we used to hold these patient events, they were very popular with our patients. We'd often have a packed room with lots of patients there for the whole day. as well as our speakers. Now, I can't see ourselves going back to this model anytime soon. It'd be difficult to envisage a lot of people taking immunosuppressant drugs being in close proximity, but certainly we do miss that close face-to-face interaction with our patients. With clinics, as you're probably aware, we've moved to a video-based model, but we hope that in the future we'll be able to offer face-to-face consultations as well, because I think it's very important as clinicians that we're as close to our patients as possible. But certainly for these patient events, we've moved to a video model. One of the advantages of a video model is that we can interact with many more patients than before. So I think as of today, we've got about 200 patients who've logged in. And what we've learned from previous patient events that very often after the event, a lot more people can actually review the meeting. So that's one of the advantages. So this is our team structure. I apologize for all the mugshots, but it's important to highlight the important members of the team. So on the left, we have Professor Athol Wells, who's our respiratory lead for the service, and also world expert in sarcoidosis and president of the World Association of Sarcoidosis. Athol's actually on another webinar at the moment, but will be joining for today's session, and also we'll be talking about treatment a bit later on. You have myself as a cardiologist and cardiology lead for the service, with also a specialist interest in heart failure and rhythm management. We have Dr. Raj Katar, consultant cardiologist and echo lead for our service. And then Dr. Shama Vachalechika, who's our nuclear medicine lead and also key for the PET program, which we've developed at the Brompton. And the protocols that we use have been replicated and used around the UK. We also have Dr. John Bakshi, consultant cardiologist and also a specialist in cardiomyopathy and cardiac MRI. So John is the MRI lead for the cardiac sarcoidosis service. And then we have Sue Gilmore, who's a specialist nurse with an interest in cardiac sarcoidosis and also heart failure. In fact, we're in the process of recruiting an additional specialist nurse because we find that patients do need the support, which often can be given by nurses rather than doctors in a much better way. And of course, Dr. Karanis, you've already heard from. So Dr. Karanis has many roles, not least he's a consultant respiratory physician, an expert in sarcoidosis, but also is key for our research program and also in organizing these meetings such as today. So why do we need a team structure in the first place? Well, one of the key factors about cardiac sarcoidosis is that very often it affects different organs of the body. Now, we know that sarcoidosis predominantly affects the lungs, and this is why the majority of patients who present to clinicians actually present to lung doctors. But when it comes to involving the heart, this is where things can become potentially more serious. But as we review patients in our MDT meetings, we need to make sure we're not missing other organ involvement. So this is one of the key reasons why an MDT or multidisciplinary team is very, very important. So we were fortunate that at the Brompton Hospital, we were one of the first centres in the UK to actually have an MDT for managing patients with cardiac sarcoidosis. And there's several key reasons for this, in addition to the fact that it's a multi-system disorder. One of the other things to highlight is because cardiac sarcoidosis is relatively rare, it's important that patients are managed in expert centres, because it's through seeing many patients with the same condition that one can develop expertise in this area. So just to highlight the epidemiology of sarcoidosis, we know that the peak incidence tends to occur in adults between the age of 20 and 40 years. And if you look at the prevalence of cardiac sarcoidosis in the literature, it ranges between 1 to 10 cases per 100,000 people. So if we compare this to other conditions which can affect the heart muscle, such as hypertrophic cardiomyopathy, for patients who have an abnormal thickening, such as in HCM, the prevalence rates have been estimated between 1 in 500 and 1 in 3,000, so much more common than cardiac sarcoidosis. So this is very, very important that these patients are referred to appropriate centers such as ourselves so that we can provide the right advice. Another reason why we feel an MDT approach is necessary is that the diagnosis is not always easy. And there's no one test that can tell us the diagnosis. So we need to make sure we review things as a team. And in particular, we put together the clinical aspects and the imaging data to try and make sure we make the right diagnosis at the onset and we exclude other important diagnoses. So just as an example, other conditions, such as this particular condition, which is a kind of muscle disorder, which can lead to rhythm disturbances and also scarring within the heart. Sometimes the imaging can be very difficult to discriminate between cardiac sarcoidosis and patients with this condition. So this is why it's important to discuss things together as a team. As I said, there's no single test which can confirm the diagnosis. There's no simple blood test or one scan which can tell us a patient has or does not have cardiac sarcoidosis. So when it comes to our MDT meetings, we're putting together the clinical features of the case. For each individual patient, we're discussing the symptoms, the way they're presented to doctors, as well as looking at the results of blood tests and results of their imaging scans. And the reason why this is important is because if you look at just one aspect in isolation, very often you cannot tell what the diagnosis is. It's only when you integrate the clinical presentation together with the results of imaging and blood tests and so on that you get a full picture as to what the condition is. And this is very important when it comes to new patients referred to our service. So as a result of this, for all new patients, they go through our MDT process, so we can give a diagnosis, and we tend to try and categorize diagnosis according to the likelihood of the diagnosis. And then we always have to keep an open mind because the condition can develop and we may have to revise this diagnosis in the future. So another reason why I think a team approach is crucial here is that patients can present in a variety of different ways to clinicians. Sometimes patients present with symptoms, but in some other cases, they may have no symptoms whatsoever. So how can patients present to our service? Well, for those patients who are undergoing screening, for example, if a patient has lung sarcoidosis, they're seeing a lung specialist. Sometimes these patients may have an ECG. They may be referred for an ultrasound scan of the heart, an echocardiogram, and that may pick up a suggestion that there could be cardiac involvement. So the patient may not have any cardiac symptoms, but may be picked up through screening. Cardiac MRI, which is a key investigation for patients with cardiac sarcoidosis, is increasingly being used by cardiologists for a wide variety of different conditions. So there are several indications for cardiac MRI scan, and frequently we get patients referred to us from other cardiologists for whom the patients had an MRI scan and the pattern of scarring or fibrosis has been suggestive of cardiac sarcoidosis without any previous symptoms to suggest this or previous history of sarcoidosis in that patient. So this is an important mode of presentation to our service. But patients clearly can also develop symptoms, and the symptoms can be quite widespread. There's a huge spectrum. They can range from palpitations, dizzy spells, fainting, sometimes breathlessness and fatigue are the main symptoms, and sometimes other symptoms can relate to heart failure. So yes, there's a variety of different ways by which patients can present to us. And as I said briefly, the condition is something which is not static, is a condition which can evolve with time. And this is why it's very, very important that when there is a suspicion of cardiac sarcoidosis, that we have an open mind. Because if we pick up a patient at the early phase of their disease, very often the signs can be very subtle, and it's not until later on that we can have a more definitive answer as to whether or not the patient has the condition. So sometimes we would actually have a consensus from our MDT that the suspicion is low, but if the patient has risk factors or if we're concerned, we will bring them back for a follow-up appointment in, say, a year or so, just to reevaluate things to make sure things haven't changed. And that's important for any disease process, but particularly relevant for cardiac sarcoidosis. So I've talked a little bit about the referral pathways, and we're very fortunate at the Brompton Hospital, being a specialist heart and lung hospital, that we have the expertise on site. And because of the history of our hospital, we do have referral pathways into the center. But we're very much dependent on patients in this area, because through patient forums such as this and SarcoidosisUK, you as the patient can drive the referrals. So if you have a condition which is rare, you should have the right to go to the center, which can provide you with the appropriate treatment. And just to show you in a graphical format what's been happening with our service, you can see in the chart here, the blue line is new patient referrals, and then the orange line are the follow-up. So in fact, this graph is about a year old. We've seen that the number of referrals has actually gone up. And despite the pandemic, we've actually maintained contact with our patients. And in fact, the number of referrals has continued to rise exponentially. This is a good thing, obviously. It means that patients are aware of our service. It means that we can develop more expertise in this area. and also gives us the opportunity to undertake research. But it's also important to realize that we must match the resources according to the demand which is out there. And certainly with the pandemic, we found that because of the kind of ability to access our service remotely, previously when patients were traveling to us from up and down the country, once they were stable, the follow-up would be often in the local center. But now that patients can access remotely, even if they live in Liverpool or in Cornwall, we can still keep a close eye on them, and the tests can be done locally, and we can review that and provide advice. So this has led to a huge expansion in our service, which I think is a good thing. So in terms of our service, where are we and where we like to go in the future? Well, at the moment, we've got 3 weekly outpatient clinics for our sarcoidosis patients. We have a new patient clinic, and then we have 2 follow-up clinics. Because this condition can be potentially serious, what we're striving to do for the future is to offer a model where every new patient should be seen within our service within 2 weeks. Now, this model exists in the NHS for cancer, and I think it should exist for cardiac sarcoidosis patients too, because a rapid diagnosis is the key to instituting treatment and preventing complications or adverse sequelae down the line. So we're putting together a business case to expand the service even more. Our MDT meeting, which is a cornerstone of our service, has been going weekly for some time now. As of September, we've expanded the meeting, we've doubled the duration, and this has led to more referrals coming through. And again, the focus is to try and discuss patients in a timely manner so that we can provide appropriate treatment options. And we do link in with other units, neurology units, dermatology, rheumatology, and ophthalmology, because as I said earlier, this is a multi-system disorder, and we need to make sure that the whole patient is managed. So this is just to reiterate the importance of networks. We do have a network with the World Association of Sarcoidosis. We're very much involved with them. We have an annual kind of conference, which we've held for many years now. Previously, pre-pandemic, this was held at the Royal Society of Medicine, 1 room, and lots of doctors coming from around the country. But now we've moved to a webinar format, which again doesn't have the same kind of advantage of being able to meet face-to-face. But when the one we held in June this year, we had over 500 doctors who attended from around the world, including North America, Europe, and also within the UK. So by improving our networks, we can improve research, we can collaborate more to try and understand how to manage this condition better. So just to end my talk with this slide on technology, we are reliant on technology in this area, particularly with the pandemic. Our MDT meetings have moved to Microsoft Teams. And the advantage here is that we can have referring doctors present their own patients. And I think this is very important. Previously, referring doctors would send in the data, we would look at the images and then feed back to them. But now with Microsoft Teams, they can log in, they can present the case, and obviously they know the patients better than we do because they've seen the patient. And I think this is facilitating improvement of patient care. And with Attend Anywhere, which is the video platform that we use for communicating with our patients at clinic, again, this has been helpful. It's much more convenient for a lot of patients who have to travel a long distance, but I think we need to move forward so we can actually see patients face-to-face in our clinic as well, because that's important for maintaining a long-term relationship. So I think I'll stop there for questions. I'll just unshare my slides. So Vasilis or Leo, did you want to ask the questions, or should I just read them from the chat?
I have a question for you, Rakesh. So great talk, and I imagine that one of the things that we have decided is that this is a consultant-led service, patient-focused. So we will largely depend on what the patients feel that their service should look like. But my question is, how do you see the future of cardiac sarcoidosis service? Do you see this as a national service? First question. And the second question is, do you think that we will go back to the model of face-to-face consultations, or is there a different plan?
Yeah, so two important questions. First of all, do we see this as a national service? Well, because it's a relatively rare condition, we need to make sure that the service which is provided is an expert center service. So certainly we're not saying we're the only service in the UK. We're fortunate that we have the largest cohort and we possibly have the largest experience, but certainly we're not the only center in the UK. But what we've seen during the course of the pandemic is, because of the increased accessibility to our service, we're very fortunate that we've been recognized as a national service. So very often our MDT, as you know, we get patients referred to us from all around the country, from Belfast, Cornwall, etc. So in all but name, I think we are the national service, but this is only thanks to referrers and for patients for putting the trust in our service. Moving on to the second part of your question, what do we do in terms of the clinic structure? Well, we've been hampered by not being able to see patients face to face, and I think that is a big drawback. I mean, video is fine, but you can't often get the same rapport as you can by seeing patients in the same room. We do understand that with the pandemic there have been restrictions, and this is something which I think we need to move to a hybrid model. So certainly for follow-up patients, they may find that actually video is fine, especially if they don't need to be examined. They may find it more convenient to sit at home and not have to travel into London via public transport or otherwise. So I think having a hybrid model will be the future, but certainly I wouldn't want to have a system for too long where we can't see patients face to face. And certainly those patients who are more unwell, who need more kind of careful management, they should have the ability to access us face to face.
Thanks, Rakesh. One of the questions from the audience is, how much aware do you think that cardiac and respiratory consultants are of the service that you offer? And I will just add to that question, and what are you doing to improve that, if this is depending on your answer?
Yeah, so the question is about awareness and how are people aware of our service. Well, a lot of this comes back to what I talked about networks. So we do link in with for example, international networks. We're also working with the ESC. We're hoping to have a working group so we can improve awareness of the condition, which will be for mainly research purposes and for guidelines. When it comes to local networks with the Brompton Hospital, we're fortunate because it's a well-established cardiac and respiratory center that we have a good reputation in this area, and we do have referrals from around the country because of those networks. Our symposia, which we've had every year, has been a very good forum for patients, for individuals rather, for consultants and specialists with an interest in cardiac sarcoidosis to link in with our network. And we have always invited specialists from other sarcoidosis units to our symposia. So it's not just Brompton centric, but certainly I think that's another way of increasing awareness. Because cardiac sarcoidosis can present in different ways, what we're trying to do is we're trying to inform cardiologists and also respiratory physicians in particular that we should have a low threshold or low index of suspicion of the disease. So for example, patients who present with unexplained arrhythmias, particularly ventricular arrhythmias or heart block, there should be a low index of suspicion and cardiac sarcoidosis should be excluded. For patients who are being seen in respiratory clinics up and down the country with lung sarcoidosis, there should be a low threshold for requesting an ECG and an echocardiogram. And certainly if patients have symptoms, they should have more advanced tests. So again, it's about education and it's about building on the networks that we have.
Just to add on that, Rakesh, from a respiratory perspective, I think that the Royal Brompton Hospital has a very well-established sarcoidosis service for many, many years. And we do try to build up our relationship with the local teams so that we follow a similar pattern in cardiac sarcoidosis service, where we ask for a shared care management of the patients, because we don't want our referrers to actually feel far away from us, but we actually want them to be engaged and try to educate them further if this is needed. So I think that shared type of management is quite key for both the referring physicians as well as us. The other question is as to whether you feel, apart from your networking, whether you think that there are ways of raising awareness with GPs, and a lot of primary care physicians have actually failed to review this in detail. What's your comment on that? And just to welcome Athol Wells, who is actually doing a parallel webinar for the European Respiratory Society, and he has been trying to be in and out of his other webinar to join us and give his views.
So what I will say to supplement what you've said, Vasilis, thank you for the introduction, and I'll keep it short. Yes, having good management of sarcoid in general and parallel is absolutely paramount. There are centres of excellence internationally graded by the World Body, and our sarcoid clinic is in the very top echelons of those centres. What I think we do have is a much larger experience of cardiac sarcoidosis than is true of most centres, but integration of the two parts is crucial. Now, I'm just commenting, it may be out of context because I've just been able to come in, so I'll stop at this point.
Thank you very much, Athol. So just to follow on from Vasilis's question, so the first thing about shared care, that's crucial because as I said earlier, we do have the fortune of having patients referred to us from all around the country. Now, patients may have heart failure symptoms, they may have arrhythmia issues, and it's important for patient safety that they're also linked in with the local centres. So we're very happy to work very closely with local centres. Obviously, we want patients to have direct access to us, and I'll talk about how we're trying to improve that in a few moments. But it's important that this is a shared care model. So patients should have the confidence that they can contact us, but they should also have confidence in the local centres. With regards to primary care, I think that's an important question. But because cardiac sarcoidosis is often considered as a rare condition and a niche condition, very often GPs would not see very many patients in primary care. In fact, the average cardiologist would probably only see 1 or 2 cases in their practice per year. So for GPs, it'll be much less common than that. So I think it's important to educate GPs, but I think the key is really to educate general cardiologists and general respiratory physicians that, yes, we should look out for cardiac sarcoidosis. And one of the points from one of my previous slides was the prevalence of cardiac sarcoidosis is quite a wide range. So previously thought to affect 5% of cases, now maybe 25% of cases, and who knows, it may even be higher than that because we may be missing a lot of asymptomatic subclinical disease. So I think having a low index of suspicion amongst cardiologists, MRI consultants, and respiratory physicians is the key, and certainly educating GPs, but involving GPs in the management and especially when patients take immunosuppression is going to be important.
Rakesh, one of the questions, I will use that as a last question, is more as a request primarily, but I will revise it in a question too. So can the cardiac sarcoidosis team document in our letters and records all symptoms reported by the patient as well as test results, not only to help with the continuity of care, but also to the primary doctors to have a full picture of what is happening? I think we're trying to do that as much as we can, but I will have your comment on that. One of the key aspects of this is that actually a lot of our patients, for either systemic disease symptoms or even cardiac symptoms, they have to reduce their working hours. This disease seems to be affecting apart from their quality of life, their actual social economic aspect of everything. And sometimes they have to apply to the Department for Work and Pensions to see whether they could get any change in any benefit from everything. So are you aware of anything that has happened in that field, and what's your view about that particular question?
Yes, I think the first part of the question was about how we can better communicate and how to have a structured way of communicating for patients' symptoms and the tests, and everything is sent to everyone looking after the patient. So certainly when it comes to our MDT meeting, which is a crucial part of our service, we have minutes which are generated at the time of the meeting. And in the minutes, we document how the patient presented, the mode of presentation and symptoms, together with the results of the imaging test. And then at the end of the MDT minutes, we have a consensus recommendations, not just on the diagnosis, but management. For our clinical letters, I try my best to adopt a structured approach as well. So we start off with the diagnosis, medication, and then symptoms, any pertinent test results, and then management plan. So I think that is what's in practice at the moment. How can we improve on this? I mean, should we having a set template? I mean, that's one thing which you and I have discussed, Vasilis, about maybe moving to a template. Increasingly, within the NHS, there are lots of different pressures which are put on our time. We're moving on now to voice recognition and dictation of our letters, so that secretaries can be freed up. That has its own challenges. Whether having a template with all the different fields filled in would be easier, I'm not sure, but certainly this is something we'd like to hear from patients more about. What information do they require and what would they like to see in their correspondence, because that can help us improve on it.
Athol, would you like to comment on the aspect of the DWP and whether, I imagine you have more experience than I do, but what I can say on that particular issue is that there is an international initiative primarily starting from the Netherlands of trying to see how we can affect the governments in taking into account our sarcoidosis and the effect of what that has in the patient's daily life, but also work commitments.
Yes, I can, but this is a vexed issue. And somebody wants me to be visible. That's generally bad news, but there you are. Let me be candid about this. In this country, there are very major blockages, unlike the Netherlands, to provide support where support is needed in some scenarios. And the blockages tend to be set in marble. They're very difficult to overturn. I know within the DWP, there have been some admirable people who approached me for support, for example, on fatigue. And I think you can apply this to cardiac issues, you can apply this to sarcoid issues across the board. But all too often it's a battle, I think you'd agree. And the fact is that for a relatively wealthy country, support in this country is set at a much higher bar than in many countries who are better able to afford support. It is probably unfair to argue, for example, that NICE stands for the National Institute for Cutting Expenditure, but I think we do have to acknowledge that we have an uphill struggle in the way in which even approved DWP statements are actually then accepted and put into action. So I do believe that the sarcoid support groups have a huge role to play. There's a suspicion always of doctors having vested interests in making statements, but we can work together to try to overcome these problems. Having fatigue actually recognized, it disables people. Having it recognized at all in this country took a very strenuous effort. And I pay tribute to DWP individuals who were very worried about the fact that they were put in this position. But then having their recommendations then accepted has turned out to be a battle as well. I'm sorry to sound this note of negativity, but it is a problem. And I think more concerted action is required.
Thank you, Athol. And I personally want to thank you from my end for what you have done about the sarcoid patients so far and all the support that you are giving to them as a patient advocate in that scenario, and that you have their voice heard in international meetings as well. I think that it is best that we move on to the second presentation. Rakesh, would you like to?
There's one question I just wanted to answer because I think it's an important one raised by one of the patients in the chat, and then we'll move on to your section. So the question is, how aware are cardiac and respiratory consultants of the service we offer? In my own case, my cardiologist was not aware and I had to find it myself. So I think this really emphasizes the importance of these patient information days, that as patients, you should be able to drive the service improvements in the UK. And certainly if you are being managed in a center where they don't have a dedicated cardiac sarcoidosis service, then you have every right to ask your specialist to refer you to us. And we're trying our best to improve the awareness in the UK, but certainly I think patients will be driving this a lot better than sometimes clinicians can. So just to move on to the next part of the program. So Vasilis is going to talk to us about our research strategy and vision, and also be introducing some of our research fellows who are part of this program. So Vasilis, over to you.
Thanks, Rakesh. I hope that you can see my screen.
Yes, we can.
Okay. I'm going to discuss about the research strategy, which has changed slightly in the last year or so with the addition of new members. Apologies for my croaky voice, which is, I will use the word necessary induced. So if we do some cardiac sarcoidosis literature review, we will find that there are a lot of challenges out there, and we're trying hard to work on answering some of the actual questions. So there is lack of an optimal screening strategy. There is a lot of time, lack of confidence around the clinical diagnosis of patients, understanding the role of immunosuppression in the management of cardiac sarcoidosis, and the risk stratification of patients with cardiac sarcoidosis. I'll show you some of the evidence that we already have, but explain what we are planning to do and what we have started doing already. So firstly, screening. And screening is a process that we are using to detect the disease at an early and asymptomatic phase. We must believe that the treatment must be more effective than after the patient develops signs or symptoms. So we have a huge work, a lot of things to be done to get to that stage, because at the moment we are just trying to see what is the actual prevalence of the disease. What we're trying to work on more is identifying the risk factors for developing the disease, such as the disease can be prevented by modifying these risk factors and basically avoiding events in the future. What we know from the 2014 guidelines, and I'll show you some more recent guidelines too, is that all patients who have a known diagnosis of extracardiac sarcoidosis should be asked about their cardiac symptoms, which is very significant. All of them need to have an ECG, preferably at every single visit, but basically definitely at baseline. And echocardiography is considered to be part of that, although in the actual document it was not really supported. In any case, the document suggests that if a patient has any of the symptoms, that is palpitations, pre-syncope or syncope, abnormal ECG, or abnormal echocardiogram, they should have at least one of the advanced imaging modalities. And the latest consensus statement from the American Thoracic Society suggests that an MRI is the scan that we use for that reason. In that particular statement, it says that every patient should have an ECG, but actually an echocardiogram and a Halter monitoring should be decided on a case-by-case basis. If there is suspicion, then an MRI should be performed, as I mentioned. In a study that this group has performed a few years ago, we found that actually symptoms have a sensitivity of 65% in detecting the disease alone, and ECG has a sensitivity of only 21%. So that shows how poor sensitivity we have from the current recommendation, which is symptoms and/or ECG. What we found in this study was that actually the sensitivity improved a lot with the addition of Halter monitoring, but even echocardiogram. However, I have a few comments on this published data that we don't really know whether Halter should be used in symptomatic or asymptomatic population. And we don't really know whether actually the poor sensitivity of the echocardiography was linked with the less advanced or the less robust techniques that we use nowadays, and we are able to detect more patients. So we have decided to set up a cardiac sarcoidosis screening study in all the patients that are referred to us with sarcoidosis to see whether actually echocardiography, as well as biomarkers in the blood or ECG, new markers, could detect more patients. We live clearly in the era of advanced imaging modalities, including the cardiac MRI and the cardiac PET. And the MRI is definitely the best tool in detecting fibrosis, whereas PET is the best tool in detecting inflammation. And we know that for a fact. What we know as well is that when these things were acknowledged, then in the previous paper that I showed you in 2014, MRI and PET were considered to be strong diagnostic criteria. What we actually don't know is how do PET and MRI integrate with each other. We actually don't know as to whether there is a genetic component to all of this and whether patients actually share some similarities with the inherited cardiomyopathy patients. So we have decided to do 2 extra studies, and you have probably been contacted in one of them. One is the magnet cardiac sarcoidosis study that my colleague Dr. Atsu is going to comment on. And we are looking into comparing the MRI and the PET as well as performing a genetic study, and I'll leave the rest to her. We're also performing a multidisciplinary diagnosis study where we're actually trying to see whether the multidisciplinary diagnosis is more validated, is more accurate than a diagnosis made using each scan in isolation. Finally, coming to the risk stratification aspect, we know that MRI can predict outcomes. So the more damage that we identify, the more likely is the patient to experience long-term adverse events. And also PET has been reported to have a similar prediction. This is a picture that shows that actually if you have both fibrosis and inflammation on the PET, it is more likely for you to experience an event in the next few years. So we have developed both a prospective and retrospective study in identifying whether what is the actual way of risk stratifying patients with cardiac sarcoidosis and evaluating the role and the safety of immunosuppression in these particular patients. We must acknowledge that the treatments that we are offering you are unfortunately close to poison. So we know that, but it is the only available treatment that we have. And I know how much you are suffering from the treatments and having a difficult time tolerating them. So it is essential to understand who will and who will not benefit from the immunosuppressive treatment rather than throwing medications to everyone that has cardiac sarcoidosis. We are bringing new information in our research, and we are planning to develop a transplant database with patients with cardiac sarcoidosis, as well as bringing artificial intelligence and machine learning in our imaging. So I will ask you to involve as much as you can to transform the clinical studies in a way that is more patient-friendly and more patient understood. This is the email that we have set up for our cardiac sarcoidosis service, and I would urge you to contact us with any specific questions that you may have for either a clinical or a research question, whether you fulfill any criteria for participating in our studies. And I would like now to take the opportunity to actually ask for our fellows to join and present themselves as well as the studies that they are working on. So I'll stop sharing. I don't know whether, Alessia, are you on the call? Would you like to take, I think, as the most beautiful and the only woman in our fellows, I think you deserve to be first.
Thank you, Vasil. It's very nice presentation. And thank you for inviting me to this very interesting event. I hope you can see my slides.
We can.
Okay, I have literally only 2 slides, so we'll be very brief. My name is Alessia Zu. I'm one of the PhD students at Imperial College and working at the Royal Brompton Hospital on this project, which is called Magnet CS, which is aiming to combine data from genetics, MRI scan of the heart and PET scan of the heart to possibly develop a new strategy, a new tool to diagnose cardiac sarcoidosis, but also to assess the risk in patients with cardiac sarcoidosis. And particularly, I would like to say which are our aims. We are aiming to identify gene change that may explain why patients develop cardiac sarcoidosis, and also possibly those genes that may explain why some patients develop more severe disease, unfortunately. Also, we would like to test the accuracy of MRI in identifying heart inflammation compared to PET, which is as Vasilis said before, the most used modality to identify inflammation. And finally, we would like to prove that not only the presence of scar and inflammation are related to risk to develop heart failure and arrhythmias, but also their extent and their location could also explain why some patients develop this severe disease. We are aiming to recruit 250 patients with the possible or definite cardiac sarcoidosis from the cardiac sarcoidosis service at the Royal Brompton Hospital, and from each patient who will consent to be involved in our study, we would like to take a blood or a saliva sample that will be used to extract DNA and perform genetic testing. We will analyze the available MRI and PET images of the heart. And finally, we would like to stay in contact with the patient for a couple of years. We will make some phone calls to ask a general question about health events, and also we will ask authorization to access hospital records and also to contact patient GPs. To the best of our knowledge, this is the first study which is going to combine data from genetics, MRI, and PET in cardiac sarcoidosis patients, and is likely to improve our understanding of this rare heart disease and hopefully help to find a way in the future to early identify, treat, and even prevent cardiac sarcoidosis. I would like to say a big thank you to the first 100 patients who have already consented and have been already enrolled in our study, and please feel free to contact me to this email address if you have any question regarding the Magnet CS study. Thank you.
Thank you very much, Alessia. I must say on this point that I'm a huge fan of our team, and I'm really happy to see that actually different doctors working in various imaging modalities in a completely different angle from each other, they are able to work together and reach this result that we have so far. I would like to introduce the second fellow, who is Dr. Rahil Ahmed. So he's a fellow that has joined the cardiac sarcoidosis service in October. And Rahil, would you like to tell us a few words about what are you planning to do, and bring a face to maybe a phone call that some of our patients have received?
Hi, everybody. Thank you, Dr. Karanas and Dr. Sharma, for holding such a wonderful event so far. It's truly an honor to be part of this. My name is Dr. Rahil Ahmed. I'm one of the cardiology registrars working as a clinical research fellow in cardiac sarcoidosis under the supervision of Dr. Sharma and Dr. Karanas. I'll just bring up my presentation, if that's okay. And then we shall get cracking. It seems like I can't share my screen at the minute because I'm going through the web browser. But essentially, my research is on risk stratification for cardiac sarcoidosis patients, and I recently started 6 weeks ago. And my role essentially is to keep a database of all the suspected and confirmed cardiac sarcoidosis patients that we have here at the Royal Brompton Hospital. So in this database, we'll keep a track of all the demographic features, the echocardiograph findings, the cardiac MRI findings, the FDG PET findings, along with the symptoms and signs and the treatment and the management that the patients are currently receiving at the Royal Brompton. By doing so, we'll be able to figure out what things are more common in patients who have got confirmed diagnosis as to those who did not have a confirmed diagnosis. And we hope to carry out a lot of research work. And one of the things that specifically we are focusing on, which has been highlighted by Dr. Karanos quite rightly so far, is about those Halter monitoring that he mentioned. For example, there's a group of people whereby implanting an implantable loop recorder might be quite useful. For example, we'll be able to find out in this patient cohort who do not have an abnormal function of their heart, whether there are beneficial in putting them in, because whether they get any rhythm problems, etc., could be identified much quicker. And in doing so, we'll be able to identify whether the role of implanting an ILR in patients who are otherwise not very symptomatic with symptoms could benefit from that. So these are some of the research objectives. And like I've specifically mentioned, it's about keeping an up-to-date database of all the patients who have been referred to Royal Brompton and keeping a track of all the different parameters that have happened from symptom signs to investigations and management. Thank you once again, Dr. Kouranos, for giving me this opportunity to come and present today. Thank you.
Thanks, Rahil. What I would say is that obviously we have done a lot of retrospective analysis, but we will use your cohort as a prospective one to validate our findings. And I will move on to Dr. Joseph Okafor, who is a new fellow that has joined our Echo department. And I would like him to say a few words about the research that he's going to carry. Joseph, welcome, and please show us what you are planning to do.
Okay. So thank you, Dr. Kouranos, for that introduction. So my name is Dr. Joseph Okafor. As you mentioned, I'm a clinical research fellow, having started at the Royal Brompton last month. And before that, I was a cardiology registrar at Imperial. And Dr. Kouranos mentioned the role of echocardiography within diagnosis, but also screening for patients with cardiac involvement who have had sarcoids outside of the heart. And as we know, echocardiography is used quite widely as an ultrasound scan, which can pick up subtle but also quite obvious features of cardiac dysfunction. Unfortunately, in cardiac sarcoid, the sensitivity, i.e. the ability to really pick up sarcoid involvement in the heart, is relatively low, about 1 in 4. But this is using basic echocardiography techniques. My study aims to think about advanced techniques, and in the last 10 to 15 years, echo has come a long way, actually, in improving the ability to diagnose not so obvious pathologies within the heart, but also an improvement in the image quality that we have. So can we use this advancement, which we have available to us at the Royal Brompton Hospital, to better pick up cardiac sarcoid in patients who don't have sarcoid diagnosed with them inside the heart? So my aim, with the help of the cardiac sarcoid team, is to recruit about 200 patients who come through to the clinic, and these patients would probably have had sarcoid outside the heart, but may have had new symptoms or been referred, i.e. from your respiratory physician or anyone who looks after your sarcoid, because there's some suspicion that the heart may be involved. Now, normally you will have an echocardiogram, you will have a detailed scan like an MRI and a PET scan. What we want to do is take this echocardiogram and make it a detailed protocol. So if we can compare these findings with the cardiac MRI and the PET, perhaps we can better pick up the conditions. So that's my study, and hopefully if you guys will be grateful in helping me along with this in recruitment, that'd be fantastic.
Thank you, Joseph. I think it's an absolute pleasure to have you on board, and I have that you have the ability to use a technique that is actually easily reproducible and available in all hospitals, which would make a difference in even the district general hospitals that do not have the facilities that we have. At the moment, I can see some of the questions. I'll try to answer a few of them. So I will just say, one question is as to whether these studies are running at the Royal Brompton Hospital or other hospitals as well. I must say that these studies are running at the Royal Brompton Hospital. We have recently merged with Guy's and St. Thomas's Hospital, but our research departments have not yet merged. So we are not able to recruit patients from GSTT unless they are referred to us. But we will soon have that ability since this is work in progress. Regarding the question about what is Halter monitoring and the risk stratification of that, Halter monitoring is a diagnostic tool that we use from time to time. And I would like to ask Dr. Sharma as our cardiologist to comment on the use of Halter monitoring and implantable loop recorder as a risk stratification tool.
Yes, thank you, Vasilis. So basically, the term Halt monitoring refers to ambulatory ECG monitoring. So what that means is that when we perform a heart tracing for a patient, that's called an ECG. But that's just a snapshot in time. It just tells us what's happening with the conduction of the heart at that moment. It can give some useful insights as to whether there could be cardiac involvement, but it's a very basic tool. If patients have palpitations or unexplained dizziness, then we may wish to take some more detailed monitoring of the patient's heart rhythm. And Halt monitoring is basically when we look at the heart rhythm over a period of time, traditionally 24 hours, but can be used for longer. And as technology has improved, we've got new different types of monitors. Some of them are stickers, they're waterproof, and so on. But in some patients, we may want even more kind of close monitoring for even longer period of time. And for these patients, an implantable loop recorder may be better. So one of the risks that we discussed in our MDT meeting is the risk of serious rhythm disturbances, and in particular, ventricular rhythm problems, which can sometimes be life-threatening. When it comes to assessing patients' suitability for a defibrillator, it's not always clear-cut. And if a patient, we believe, may have an increased risk, but doesn't quite fulfill the criteria for defibrillator, we may actually propose a loop recorder. So what this is a small chip-like device which is implanted under local anesthetic under the skin, and this monitors the heart rhythm continuously. And if the patient develops any symptoms, they can send us a reading of their heart tracing using their smartphone, or if the chip picks up a rhythm disturbance, then we get an alert. So this is technology which is not new, but it's something which we're increasingly using for our sarcoidosis population. And I think it's particularly important for those patients in whom we think there could be an increased risk. And we're carrying out a research study in this area.
Thanks, Rakesh. One of the things, before I turn to some of our fellows as a question, one of the things that I would like to say, because there was a question how patients could help us. I think that the patients help primarily by participating, but more importantly, we now ask the patients their view about some of our study design. We would like to have some patients representatives in participating in our study design, so that our studies are friendly for the patients and they actually answer the questions that the patients want. I must admit that I have frequently consulted some of our patients, but also have spoken in length with SarcoidosisUK, which is the largest patient advocate, to my knowledge, in the country, for getting more advice about how it is best to design a study in the future. Regarding the question about the magnet study, Alessia, one of the questions is, if a patient has a device, does this mean that he doesn't qualify for your study?
Thank you for this question. No, they still qualify for the study because we can still look at the genetic information, and also we can still compare PET and MRI images to look at scars and also inflammation. The MRI scan of a patient with a device can still show inflammation, and we can still compare with the PET images. So it is not an exclusion criteria.
Thank you. I will answer the question with regards to any measures that we have in identifying flares. So part of the risk stratification study that I just mentioned, although we're looking for events, cardiac events in the future, we are taking into account how many patients may relapse over time, and therefore we will see whether there are any actual measurements at the baseline evaluation of the patient that would predict who is going to have a flare down the line. Is this related with reduction of the level of immunosuppression or not? Just to say one more comment about whether the risk stratification is covering both patients with active and patients who are in remission. It depends on how you see this, and the majority of the risk stratification studies are evaluating baseline assessment and any associations with the future events. But nowadays, with the help of Professor Wells, I have been looking into the serial changes of all the tests that we have to see whether actually this is helping us better predict the future. So evaluating whether change in the individual tests would actually predict the outcome. The last comment is as to whether there is any psychopathology of sarcoidosis. We'll try to answer this later on in our clinical session, but there isn't any research going on at this field at the moment. So without further ado, I would like to introduce our next speaker, who is Peter Thickebone. I'm really proud to have him today as the president of SarcoidosisUK, who I would like to share with us the vision of the charity, as well as the charity's aims for both the clinical and the research aspect.
Thank you very much, Vasilis, and thank you for the invitation to speak on behalf of SarcoidosisUK today and to be involved in this event. Just for everyone on this call today, hopefully you're all aware now of SarcoidosisUK. If you're not, we are, as Vasilis just said, the UK's leading patient advocacy and support group for sarcoidosis. Our primary focuses are obviously in terms of supporting patients. We do a huge amount of work with information on our website, with supporting days such as today, with video snippets and etc. So there's a lot of information about sarcoidosis. Also, in terms of research, we fund research on an annual basis. We actually raise several £100,000 a year, which we use on research and support. And largely for our research projects, these are seed projects. We're not as big as someone like a large cancer charity, but we do support seed projects that allow potential cures, treatments, and etc. to be investigated, and hopefully seed further larger trials from that. Our support extends to helpline. We actually have a helpline that's staffed by 3 nurses, one of which is a specialist in cardiac sarcoidosis. So if any of you have any queries, that obviously you can direct to your consultant, but if you have anything that you would want to ask a question about, we can book a call with one of our nurses and give you some support. And of course, a large part of what we do is advocacy as well. So as Vasilis just said, we are a source of support in terms of patient representative, and we work quite closely with clinicians, researchers, and of course the Royal Brompton on supplying information, surveys, and etc. I think with regards research, a lot of our focus in the past has been on general research into causes and treatments for sarcoidosis as a whole. In future, what we're looking at is setting up our own research panel. Now that we've grown as a much larger and more complex charity, we are now looking to set up our own research panel where we'll be able to call for and support more research into cardiac sarcoidosis in conjunction with a number of the consultants and researchers and etc. on this call. I think that one of the other areas of particular focus for any of you that participated in a survey earlier this year, where we asked for input about the direction of the charity, is also putting a greater focus on education and awareness broadly in the community, but also in the clinical community, making sure that we're doing more to support you with your conversations and getting a diagnosis at primary care level, and making sure that people are much more aware of the impact of sarcoidosis on people's lives. I think where you can support us and obviously support the researchers as well is quite often we ask for engagement in patient surveys and information. A lot of this helps direct our direction in terms of focus on research, advocacy, and cure, etc. But also part of it informs the kind of things that Vasilis was talking about earlier. We, as a patient representative group, we are able to pull together a lot of information we're able to share with clinicians and researchers that allow them to think about and take account for the patient voice in where, you know, in the direction that their work goes. So I would ask that every time you see something, well, first of all, follow us if you don't already, and of course, you do visit our website. Make sure that you have a look at all the information that's already available. Things like these days, we record them and post them on our website. So there's a lot of information going back in time over the last 12 months. Of course, you engage with us on social media, get involved in support groups, which we also facilitate, and contact us on that if you want to know about a local research support group. If you want to support and talk to one of our nurses, by all means, get in touch and we can facilitate that. But finally, of course, all of this work that we do requires the support of you and your supporters and the community as a whole, and raising money is also very important. So if anyone is able to donate, that would be terrific. You can find our website at sarcoidosisuk.org/donate for donations. So please do help. I wasn't really intending to answer any questions, but there is one in here. I think, you know, the point that you make there, is that Kirsten? The point you make there, Kirsten, I think is one that we're aware of, and it is feedback that we get quite often about the knowledge and awareness of sarcoidosis as a whole when it comes to first diagnosis in primary care. And that's one of the reasons why not only are we looking to research for treatments and a cure, but also increasing our focus on the education front. And that's going to be a big thing for 2022 to make sure that we're making that our reach gets ever greater when it comes to getting information out to primary care. That's it from me, Vasilis, unless anyone else has any other questions.
Thank you very much. Thank you very much, Peter. I must say that I think you are helping us. You're helping us a lot, and I'm really proud to work with you closely in all our events. I just want to say that on top of everything, you are a member of the advisory group of the European Lung Foundation as well, which is helping in designing studies at an international and multi-center level, which is quite important for the representation of the SarcoidosisUK patients. And thank you for that. Thank you for all the work that you are doing. And I must say that at least from the Royal Brompton Hospital, we will be close to you to help you with what you are doing for our patients and patients with sarcoidosis in general. I think that we can go on to a break so that we prepare ourselves for our next session, which will be more clinical information about the disease diagnosis and management. So I'll see you all in about 15 minutes. Let me see the program exact. Rakesh, am I correct?
Well, the program says a break until 12:40.
Okay.
But if you like, we can start a bit earlier. Should we say 20-minute break? Should we say 12:30? Should we start
12:30? I think that's fine.
Okay, 12:30, everyone. So have a cup of coffee or a quick lunch, and then we'll log back on for the afternoon session in 20 minutes. Thank you very much.
Thank you, everyone.